we're going to perform the tap or percussion test. So I'm going to have my patient sitting in a chair. I'm going to have her with her hand on the table. I'm going to stabilize her hand with her finger in extension. And I'm going to tap the end of her finger, her DIP. And you can use a percussion hammer. And pain at the site, if she has pain with this, that would be indicative of a fracture.
Okay, so to take this test a step further, because again, we focus on foundations for examination, differential diagnosis, and prognosis. So, what in the patient's subjective report would lead you to perform this test?
I think she fractured her finger. Oh.
So we don't know if she fractured her finger. We have direct access. So this patient just comes to us and report pain, a specific type of pain. So say the patient says that she has dull pain in her fingers. In her finger, the dull pain is constant. And say that it's exacerbated with movement, right? And so she reports a history of trauma or fall onto her hand or fingers, right?
Yes, sir.
All right. So the report of trauma, the patient reports not having x-rays, okay, no type of imaging. So that would kind of lead you to performing this test to assess for fracture.
Yes, sir.
Okay. Now, why would you want to pay attention to what type of pain the patient reports?
If they said it feels like a sharp pain or a particular pain, that could be an indication for something else.
So yeah, so if they say sharp, burning, numbness and tingling type sensation, pins and needles, fluctuating between hot and cold, all of those are indicative of some type of nerve involvement, some type of neurological impairment. But typically if they say dull, is most likely could indicate bone or some type of vascular involvement. But the subjective report in conjunction with the pain report is going to direct you all towards your special test. Because remember, you have a patient with a new eval 60 minutes. You don't have all day to do that evaluation, right? So now you got to listen closely to what this patient tells you, all right? You got to listen very closely to what the patient tells you. And you need to know your pain descriptors off the back of your head. So a patient comes say aching, throbbing, what are you thinking? You're thinking muscle, some type of soft tissue involvement, some type of connective tissue involvement. I'll perform the long finger flexion test on page 125.
So for the long finger flexion test, the subject can be sitting or standing, so I'm going to have Kendall sit. The examiner stands in front of the subject and holds the subject's fingers in extension. For the finger being tested, so for this, I'm going to test the second phalange. The examiner isolates the DIP by stabilizing, so I'm stabilizing the DIP. The proximal interphalangeal joint and middle, so I'm stabilizing all of these. The subject instructed to flex the finger being tested at the DIP joint. So flex right here. The examiner isolates the proximal interphalangeal joint by stabilizing the metacarpal joint and the proximal phalanx. The subject is then instructed to flex the proximal interphalangeal joint. Okay. A positive finding would be if the subject is unable to flex the PIP, then both the flexor digitorum profundus and the flexor digitorum superficialis muscle tendon and or nerve are compromised. If the subject is able to flex the PIP joint but is unable to flex the DIP joint, then only the flexor digitorum muscles, tendon, or nerve are compromised.
Okay, so good. So Dr. McClure and I are going to be looking to see if you're stabilizing where you're supposed to stabilize. So I'm gonna come right here, right? I'm gonna stabilize her MCP and her proximal phalanx. And I'm gonna tell her to flex your finger right here. So I'm telling her to flex at the PIP, right? But guess what? I have my stabilizations in the proper place. All right. So what does this tell me? Now this tells me that her flexor superficialis is intact. Okay? Her flexor digitorum superficialis is intact. Why does it tell me the superficialis is intact? I know that superficialis crosses the PIP, all right? Now, what if I want to do, if I want to find out if both the flexor superficialis and digitorum profundus are intact? So now I got to make sure that I stabilize, okay? I'm stabilizing the proximal and middle phalanxes. So you have to be able to verbalize this. And I'm gonna have her to flex right here at the DIP. So now she's able to flex at the DIP. So now I know that her superficialis, flexor superficialis is intact, and her flexor digitorum profundus muscle is intact. At this specific phalanx. So at the second phalanx. And I could do the same thing for each phalanx, right? Because it could be that she doesn't have any involvement at this phalanx, but could have involvement at another phalanx. So if I really want to, I can assess all of them, okay? Always do it bilaterally, okay? So you're gonna do it bilaterally. Why do we do it bilaterally? Because we have to compare, right? So if the non-involved indicates or represents the person's normal, then the involved is going to let us know, okay, the non-involved is let us know how the person typically performs under good condition, healthy muscle, healthy joint, whatever the case may be. The non-involved side is going to let us know how the person typically or normally performs a motion or a task, or whatever the case, or function. Then we come back and assess the involved side and compare it to the non-involved side. Okay, that is how we identify problems. So make sure you know the innervation for the flexor digitorum profundus, and also for the flexor digitorum superficialis is what kind of complaints or presentation would someone present with that would direct you to the long finger flexion test. But with the long finger flexion test, who could tell me what is something that your patient may subjectively report to direct you to performing the long finger flexion test? Pain with what? Okay, they could have pain with grasping things, so that's good. Huh? Could have aching pain. So aching pain with finger function, with flexion of the fingers, okay. They could have pain with extension of the fingers too. You don't know, all right? Is the pain, so tell me this, so we said aching pain. Would the pain be more so, would it be localized or would it be diffuse pain? So localized, they can pinpoint the pain and go right to it. So typically, if the tendon is ruptured in a certain point, they may be able to localize that pain. So they may be able to go point to that pain and identify the exact area of that pain, okay, if a tendon is ruptured, okay. Also, the deficits may be localized to that specific tendon being ruptured as well. So this just give you some things that you need to be listening for with the patient. Now the patient could have a report of trauma with this as well. Or it could be a tear due to overuse. I mean, we don't know. We have to dig this out of the patient. But most likely, if it's muscular tendon unit involved, or aching pain, throbbing pain, a combination of all of those, okay?
Finkelstein test. So we have the patient can be sitting or standing. So we're just gonna have her sitting. Gonna have her hand in the neutral position. The examiner stands with the proximal hand grasping the subject's forearm and distal hand grasping the subject's fist. While stabilizing the subject's forearm with the proximal hand, ulnarly deviate the subject's wrist with the distal hand. So I'll move it in this direction here. Pain over the abductor pollicis longus and extensor pollicis brevis tendons distally is indicative of tenosynovitis in these tendons, or de Quervain's disease. This test may create pain in uninvolved tissues. The examiner may also find simple passive ulnar deviation may be slightly uncomfortable for those without pathology. If de Quervain's disease is suspected but pain is not found with ulnar deviation, then the examiner can have the subject radially deviate against resistance in an attempt to reproduce contractile associated pain.
What type of subjective reports is your patient going to report with that?
Maybe pain when driving.
Maybe pain with driving, yeah. They could have tightness. So pain with driving or gripping the steering wheel, yeah, most definitely. What else could they report? Pain with turning doorknob. Okay, pain with turning doorknob, that's good. What else could they potentially report? Okay, they could report pain with grabbing a soda, a can of soda or a glass and picking it up to drink. Yeah. What else could they report? Pain with writing. Yes. What else they could report? Sometimes patients may report neurological symptoms with de Quervain. Sometimes they will. Okay. Pain with squeezing. What else? What's our favorite thing we like to do now? Text message. Pain with texting. Now, textbook wise, text messaging is one of the overuse factors, one of the activities that typically cause de Quervain now. So these are just signs and things to listen for that prompt you, that would lead you to doing a special test. So remember, you're not just doing these special tests for no reason. You're listening closely to your patient. So most cases, patients are going to report pain in the region of the anatomical snuff box or the lateral aspect of the distal forearm and wrist hand region. Phalan test, page 129.
Subject sits or stands with the dorsal aspects of both hands in full contact so that both wrists are maximally flexed. A steady compressive force is applied through the subject's forearm so the subject's wrists are maximally flexed for 1 minute. Numbness or tingling in the median nerve distribution of the fingers are indicative of carpal tunnel syndrome secondary to median nerve compression. Pain in the wrist area without complaints of radiating pain distally toward the hand and fingers may be indicative of carpal bone pathology.
All right, so thank you, good job. So with your Phalan test, what type of things are your patients going to report with the Phalan test? So typically, numbness and tingling in the median nerve distribution, right? They could also report burning. Some do report burning sensations. Some report like different abnormal paresthesias. Some may not be able to explain it. Now, what type of occupation is this person going to report that they typically do?
Right.
Office jobs, typing at the computer a lot. What else? Braiding, yeah, could be braiding. A cosmetologist, someone who braids and does hair. What else?
What about a dentist?
A dentist likely could. Likely could. Present and report, perform things that could cause carpal tunnel. Another hallmark activity. What's another activity that someone could perform a lot of? They like to put this and use this on tests. Gardening, yeah. So yeah, so they love to get a history of a person being a gardener and performing repetitive activities of extension, and resulting in carpal tunnel syndrome. Okay, so inflaming. So what structures are involved with carpal tunnel syndrome? The flexor retinaculum. Okay.
It says that the subject sits next to a flat surface, and then the examiner taps the volar aspect of the subject's wrist over the area of carpal tunnel. First, I'm gonna grab here, and then tap over the area of the carpal tunnel. It says tap. Well, I made note to tap hard to reproduce symptoms. Okay.
You got to tap on it. I'll get here like this. Okay. But just like he did with the percussion test earlier, you know, you can start gentle, see if that, sometimes that's enough to provoke it, and if not, you can get a little bit more firm with your tap. Okay.
It says complaints of tingling, paresthesia, or pain by the subject in the area of the thumb, index finger, middle finger, and radial 1/2 of the ring finger signal a positive test. It could be indicative of compression of the median nerve in the carpal tunnel or carpal tunnel syndrome. Yeah. And it says, again, the subject may sit or stand, and the examiner sits. The subject is instructed to hold a piece of paper between the thumb and index finger. Thumb, index finger. Yeah, hold it. Oh! Between the thumb and the index finger. And then the examiner then tries to pull the paper out.
I want you to look at the picture. All of you look at the picture in there. Okay? It's kind of like this. You want to get it right in between the tips. Okay? It's important that you get it right between the tips like that for this test to do it accurately. Okay?
Okay, and then it says flexion of the phalangeal joint of the subject's thumb is indicative of adductor pollicis muscle paralysis due to ulnar nerve damage. And then it says special considerations of the simultaneous hyperextension of the metacarpal phalangeal joint of the thumb is indicative of ulnar nerve compromise. For G's side? Did I see it?
Genie's sign. Could be Jan's sign. I don't know.
That is an excellent case for this. So with the special considerations with the Froment sign, it indicates that the person could hyperextend in conjunction with flexing, excessive flexion at the DIP. So hyperextension can occur at the MCP simultaneously with excessive flexion at the DIP. Does that make sense? So Pujan's about to show you what that looks like. So come right here, I'm pulling. So if you come and look, if you can come look, see if you can capture this. So he has excessive flexion at the DIP, but the metacarpal is in a sense moving more lateral, so it's moving into more extension. So his LCP joint is simultaneously moving into more extension as the DIP excessively flex. Does that make sense? So those two can occur simultaneously with a positive Froment sign. Thank you, Pujan.
Sure. I'm going to put his finger into slight extension. The metacarpal phalangeal joint and slight extension, and passively flex the proximal interphalangeal joint. And assess the amount of proximal interphalangeal joint flexion. Then I got to passively flex the metacarpal phalangeal joint slightly, and then assess the amount of flexion at the PIP joint. There you go. Positive finding for this is revealed that the PIP joint does not flex while the metacarpal joint is extended in the extended position.
And it says if the PIP joint does fully flex once the metacarpal phalangeal joint is slightly flexed, intrinsic muscle tightness can be assumed. By contrast, if flexion of the proximal interphalangeal joint remains limited once the metacarpal phalangeal joint is slightly flexed, capsular tightness can be assumed.
Okay. So that's simple, right? Very simple. So you gotta tell yourself it's simple so that you can retain it. So if it doesn't flex while the PIP is extended, what is it as a positive finding for?
Intrinsic muscle tightness.
That's what you have to know. It's a positive finding for intrinsic muscle tightness if it doesn't flex while the MCP is extended. But there's a catch to it. There's one final thing you gotta determine. You gotta go ahead and flex the MCP.
Yeah.
Why? Before making that determination.
Give slack.
It just, got it?
So you give slack to the intrinsic muscles.
There you go, yes. So now you give slack to the intrinsic muscles, and now you can make a clinical impression that if it does flex at the PIP while flexing the MCP, then that's your final confirmation that it's positive for intrinsic muscle tightness. Does that make sense?
Yeah.
So this is a hypothetical scenario. So say if the person MCP is extending and you don't get any flexion, all right?
Yeah.
Now, say at the PIP, now say if you flex the MCP, all right, and then you still don't get any flexion at the PIP. Capsular tightness, okay? So you wanna think capsular restriction in that case. Now, and when it says intrinsic muscle tightness, what muscles are we talking about? Your interossei and what else? Your lumbricals, okay? What functions do the lumbricals perform at your phalangeal joints?
The metacarpals are the ones that help from flexing, and the interphalangeal are the ones that helps them extending. So they can help with the joint movement doing both at the same time.
Okay, so now with that said, you got to know the function of the lumbricals at the MCP and also the interphalangeal joints, okay? What type of patient would likely have a positive Bueller-Littler test? Rheumatoid arthritis affects mostly the hand, and so if you have an inflammatory process, it inhibits muscle contraction, right? So it can cause muscle wasting because the patient don't move through the full range of motion. But then also the joint capsule is affected. So this is a condition where somebody can have a positive Bueller-Littler with intrinsic muscle tightness and joint capsule restrictions. Does that make sense? So let's use Ebony as a case. So Ebony, go ahead, go into the prayer position. This is the reverse phalanx position, right? And so look at what's happening with Ebony's fingers, especially on the left side. I'm looking at her fourth PIP joint. I'm looking at her third PIP joint. And what's happening at those PIP joints? They are flexing, right? Her DIP joints are an extension, right? So now just looking at this, I did the Bueller-Littler test on her. Her Bueller-Littler test was negative. So I'm giving y'all some information. So if her Bueller-Littler test were negative, what does that inform you? So that it's not the intrinsic muscles, it's not the deep intrinsic muscles of the hand, nor is it joint capsule problems. So what are you thinking that it could be that could be flexing her so at the PIP? Tightness with the flexor digitorum superficialis, okay? Her DIPs are still extended. So now you're just using your knowledge of muscle action and how the muscles act at joints and origin and insertion as well, okay? Because her DIPs were still extended now. And so if they were still extended, if the flexor digitorum profundus, if they were tight and pulling in the direction that they were supposed to pull in, what would happen at the DIPs as well? Flexion. So it's like looking at what you see, understanding muscle action, understanding some origin and insertion, and putting the things together. Now,
So for the valgus stress, we're going to provide a valgus force on the joint, creating a fulcrum to gap the joint. So we're going to stabilize just past the MCP, and then we're going to grab also at the DIP, and we're just going to push towards those other fingers on the outside of the joint. And a positive finding would be excessive gapping that's noted when compared to the uninvolved side. So it may indicate a contralateral tear.
Another one, be real aware of your anatomical position, 180, stupid 80, moving stuff around. Be real careful with how you name stuff with this, okay?
did you do it one time for you? Okay.
And then varus stress is going to be very similar, except you're just testing the other direction of the force. So you're going to stabilize in the same areas, and you're going to provide that varus force going towards the thumb side of the hand. And once again, the positive finding is excessive gapping, which is an indication of a contralateral tear on that side.
Okay. All right. Good. So again, take note of what Dr. McClure said with those. When would you perform these tests? What would a patient, what could a subjective report sound like with that would lead you to perform the varus and valgus stress test? Somebody would have been playing basketball or even football and said that they jammed their finger and it didn't have pain, likely with ligamentous pain, likely they're gonna report dull aching pain, could be throbbing pain as well, but ligamentous is non-contractile, so patients could be all over the place, but you gotta listen closely to the subjective report. So that's a good one. Anything else?
Someone had like a recent dislocation of a finger.
Okay, recent dislocation, which could result in ligamentous laxity, or ligamentous laxity can be the cause of it as well. Good. Anything else? Anybody can think of? Because it's always good to know why you would do this special test or what would direct you to doing it, and also it's good to know what condition would you use this special test for. Okay. Again, I'm harping back on RA again because rheumatoid arthritis causes laxity of ligaments as well, and so that's one where somebody could present with an excessive valgus or varus. Oh, so also there are certain conditions to where patients just have decreased tone, a lot of laxity in the joints, and it could be just they're normal. Who could think of a condition where Down syndrome? That's what I was thinking. So she took it right out of my mind. Dominique went right from my mind to her mind. Down syndrome. So patients with Down syndrome, they just gonna, a lot of them are gonna be lax. They probably gonna have a positive ligamentous laxity type of test. So that may be their norm. But how do you know it? Assess both sides. If both sides are the same, that's their norm. We have pitch paper test. That's the same as Froment sign. So we've already done that. But it's also considered a functional test. So just know that. And then we have the thumb, active range of motion, abduction, flexion, and extension with a rubber band. So then we have any rubber bands in here? So we have thumb, active range of motion. So we got abduction. So seeing if the person can move into abduction, right? With the rubber band. All right. Seeing if your patient could perform flexion, kind of made like a figure 8, put it around the thumb, and to see if they can move into thumb flexion. And then extension. So I'm gonna keep the figure 8 on there, see if they can move into extension. Extension, flexion, abduction. Quick functional assessment to assess thumb active range of motion. and lift up from a table with a cylindrical grasp for finger flexion test. So that's patient being able to do this. Let's see if they can grasp it and just lift it from the table. Very simple. Okay? What would this assess? That assesses a whole lot. Like, what are some special tests that we talked about that if they're positive, the person may have a tough time doing this? Finkelstein test, this could reduce some pain. What else? They could have some difficulty with this. What else? Tap test, if they have a fracture, they could probably have difficulty with this. Yeah. What else? Long finger flexion test. You know, if they got some involvement anywhere along one of those fingers, they could have some report difficulty with this. What else? What else? The Borneo litter? Yes, most definitely with the Borneo litter. This is actually one of the treatments for Borneo litter. Just have the patient practicing, picking up and grasping a mug. So that could be a positive special test that where they can have difficulty with this functional test. So typically when you assess as a PT, when you go through all of your assessments, you always want to incorporate a functional assessment. Why? Because we are in the business of improving function.